For this video, we will be focusing on several different antibiotics that all disrupt either the integrity of the bacterial cell wall or cell membrane, and this will eventually lead to bacterial cell death. So now let's discuss our first agent, which will be aztreonam. Now, aztreonam is incredibly similar to our beta-lactam antibiotics. So it is actually a monobactam, meaning that it retains that beta-lactam ring structure, but is lacking the adjacent ring structure that is generally found in the penicillin, cephalosporins, and carbapenems. So because it still retains that monocyclic beta-lactam ring, its mechanism of action is identical to the beta-lactams, where there is inhibition of penicillin binding proteins, which remember are transpeptidases, leading to an inhibition of peptidoglycan cross-linking, interfering with cell wall synthesis, leading to bacterial cell death. So aztreonam is generally characterized as bactericidal, just like the beta-lactams, and has great aerobic gram-negative coverage, including anti-pseudomonal activity, but has no gram-positive or anaerobic coverage. So may be combined with other antibiotics to achieve a more broad spectrum regimen. So one of the primary resistant concerns is similar to the beta-lactams, being those ESBL producing organisms. Just like most of the beta-lactams, it is renally eliminated and will require renal dosing adjustments. Now, this agent shares a lot of the common adverse drug reactions for most of the antibiotics, but one important thing to note for this agent is that there is very little risk of cross-reactivity in those with a penicillin allergy, despite its structure. So this is actually considered a safe option in the penicillin allergic patient. So this agent fits a particular niche with its gram-negative coverage and its anti-pseudomonal activity and safety for the penicillin allergic patient. So moving to our next slide. Now our next agent is vancomycin, which is a glycopeptide antibiotic. And vancomycin, or vanco, is an agent that is very important to become familiar with. So the way in which vanco works is by binding to the growing peptidoglycan chain in the peptidoglycan layer, inhibiting any further polymerization and further cell wall synthesis, leading to downstream bacterial cell death. So this agent is considered bactericidal and has great gram-positive coverage, including MRSA, for example, but no gram-negative coverage. But because of growing resistant rates, like with vancomycin-resistant enterococcus or VRE, its IV use should be reserved for mostly serious infections requiring MRSA or other beta-lactam-resistant gram-positive coverage. So for PO administration, it is not absorbed, so bioavailability essentially equals 0. So it remains in the GI tract because it cannot be absorbed because of its large size. So PO, it is actually used for GI infections like C. diff, for example. So now this agent's IV dosing, which is what we'll focus on in this video, is somewhat unique compared to other antibiotics because it is a narrow therapeutic window drug. So vancomycin will usually require a loading dose, especially for serious infections, which is then followed with a maintenance dose. So because we are talking about an antibiotic, we want to remain above a certain threshold, above the minimum inhibitory concentration, or MIC. So we follow a trough concentration, and this is used to monitor therapy. So what does this really look like? So if we have our concentration time graph here, so say our minimum inhibitory concentration is down here, and then our threshold we need to remain above is essentially our minimum effective concentration. So when we dose our vancomycin, we want the patient to remain above the minimum effective concentration, which is our trough level, and then redose again, maintaining them above that minimum effective concentration, and hitting that target trough concentration at the end of our dosing interval. And generally the target trough concentration is between 15 and 20 micrograms per milliliter. And then once you have a trough concentration, this is used to monitor therapy, and you can dose adjust from there to ensure the patient remains within your target therapeutic window. So understanding the drug's dosing interval versus half-life and knowing when to order a trough level before the next dose is incredibly important to ensure this patient is an appropriate vancomycin regimen. So now we do have to worry about the risks of toxicity that come with vancomycin, because remember, again, this is a narrow therapeutic window drug. So it does come with some serious risks, and troughs higher than this target level do lead to an increased risk of ototoxicity and nephrotoxicity, especially when given as a regimen with other antibiotics that cause these toxicities as well, or in renal impairment because this antibiotic is renally cleared. And the more the patient is exposed to this drug, the more risk of these adverse drug reactions. So another adverse drug reaction to watch out for with vancomycin is vancoflushing syndrome, which happens with too rapid of an infusion of vanco, which leads to things like hypotension, flushing, pruritus, nausea and vomiting, and other effects. And this is due to a release of histamine triggered by the vancomycin infusion. And this is similar to the reaction we discussed for some of the opioid agents in block 4 with a pseudo allergy. So if this occurs, you can just stop the infusion, give an H1 and H2 receptor antagonist, and reduce the infusion rate. So again, vancomycin is an incredibly common and useful agent, but special care must be taken to understand its pharmacology to ensure appropriate use and dosing for patients and to minimize any mounting resistance to this agent. So moving to our next slide. The next agents we'll discuss are the lipoglycopeptides, which are telavancin or dalbavancin. And these agents are very similar in mechanism of action to vancomycin, where they will both bind to the growing peptidoglycan chain to prevent further cross-linking and cell wall synthesis. And these agents also have a lipophilic tail group that allows them to insert into the bacterial cell membrane and disrupt bacterial cell membrane function, also leading to bacterial cell death. So these agents are similarly bactericidal and provide broad gram-positive coverage only, including some highly resistant pathogens like multi-drug resistant strep, MRSA, vancomycin resistant Staph aureus, just not vancomycin resistant Enterococcus. Because of this activity against highly resistant pathogens, these agents are reserved for only those infections in order to prevent overuse and increasing the risk of resistance. So for elimination, telavancin is renally eliminated, requiring renal dosing adjustments, but dalbavancin is a mix of both renal and hepatic and doesn't need dosing adjustments. And the adverse drug reactions are going to be many of those applicable to most antibiotics that we already discussed. So these agents will be reserved for those specific instances where highly resistant gram-positive organisms are at play to help minimize its overuse. Now moving on to the next slide. Now our next agent is daptomycin. And this agent is a cyclic lipopeptide that can bind and insert into the bacterial cell membrane. And these daptomycin molecules can form a pseudo-like pore in the cell membrane that allows the leakage of ions from inside the bacteria out, leading to bacterial cell membrane depolarization and an inhibition of intracellular function and rapid bactericidal effects. So like the lipoglycopeptides, daptomycin has broad gram-positive coverage, including a number of resistant strains like MRSA. And unlike the previous group of agents, we now have vancomycin-resistant Enterococcus or VRE coverage. However, one important thing to note is that this agent cannot be used for pneumonias because the pulmonary surfactant actually inactivates daptomycin, so it loses its antibiotic effects. So this agent is renally cleared, requiring dosing adjustments. And as for adverse drug reactions, if you remember back to the rhabdomyolysis video in block 3, daptomycin is one of those agents we discussed with a risk of rhabdo because it is thought to similarly form pores and lead to mitochondrial membrane depolarization, potentially leading to rhabdo. So CPK levels have to be monitored during therapy. There is also a risk of neuropathies and eosinophilic pneumonia with this agent as well. So again, similar to the lipoglycopeptides, daptomycin will be reserved for those infections with pathogens that are highly resistant, like those resistant to beta-lactams and vancomycin. So moving to our last agent. So our last group of antibiotics for this video will be the polymyxins, like polymyxin B or E. And polymyxin E is also known as colistin. And these agents are cationic peptides that have both a hydrophilic region and a lipophilic tail. So the cationic regions will displace cations in LPS, or the lipopolysaccharides of the bacterial cell membrane. And the hydrophobic tails of the polymyxins will disrupt the lipid bilayer of the membrane through a detergent-like effect, leading to cell membrane disruption and bactericidal effects. So polymyxins are sort of a last resort antibiotic used in the management of systemic infections caused by susceptible strains of multi-drug resistant gram-negative organisms like Pseudomonas. And may be the only effective option for some multi-drug resistant pathogens like carbapenem resistant Enterobacter infections, for example. So just so you are aware, these agents can be administered systemically for serious infections, and they're also applied topically to prevent skin infections because polymyxin is actually one of the components found in triple antibiotic ointment, for example. But in this video, we're going to really focus on the IV administration. So the most common and clinically concerning adverse drug reactions of IV polymyxins is nephrotoxicity. And polymyxins have been associated with hematuria, proteinuria, oliguria, and even acute renal failure. So during therapy, renal function needs to be followed very closely during administration, and the concurrent use of other nephrotoxic drugs should be avoided. So neurotoxicity can also occur, even neuromuscular blockade, which can lead to respiratory failure. However, the most common neurotoxic effect is paresthesias, and combining neurotoxic drugs should also be avoided. So this drug also, as you can probably guess, is a narrow therapeutic window drug. So therapeutic drug level monitoring and monitoring for these nephro and neurotoxicities are going to be necessary. And these are listed as black box warnings for these agents. So because of the serious risks associated with this agent, and we don't want to inappropriately use this agent leading to pathogens developing resistance to our last resort antibiotics, it is important to be aware of this agent even though it is not as common. So moving on to our summary slide. So this concludes our discussion of antibiotics targeted at the bacterial cell wall or cell membrane beyond the beta-lactams. And I hope this video has highlighted several very common agents as well as a few that are less common but are very unique that you should become familiar with. And as I mentioned in the previous antibiotic videos, I would encourage you to keep practicing grouping these agents according to characteristics that we discussed in the beta-lactam video. That should help you organize these agents so that you can easily recall them when necessary in a clinical setting.